Miriam is 32 years old. She is living in the remotest district in central Afghanistan. She is now pregnant, and she has been having a health problem. She is not feeling well, and she has headache. She cannot properly eat. She cannot walk. She is part of the community. She approached her family and the community that she is part of it. Everyone from the community and also from the family has been trying also to help her, but they don't understand properly how to help her. So for the first time, she approached one of the shops that they are selling medicine to buy a medicine. Unfortunately, it does not help her health. So her health was getting worse. Later, she also approached shrine, traditional healers, religious scholars. What she was advised not to eat anything for 40 days except water, melting in a piece of paper that something was written on that as a note. Unfortunately, her health is getting worse. She is really stressed because the mortality in the village and also in the district where Miriam is living is very high. Most of the pregnant women, newborns are dying. This is not only Miriam. In the world, in every 11 seconds, a pregnant woman and newborn die around the period of delivery. Afghanistan is also one of the countries with the highest maternal mortality and newborn mortality. In less than 1 hour, a pregnant woman or a newborn die from the preventable cause. Well, the life is preventable, so we can prevent the death by very basic community-based intervention. A skilled pair of hands to help along with clean water, basic medicine, adequate nutrition, and vaccine. Well, this is also only possible when you work with the community, when you involve the community. In 2014, I got an opportunity to work in the similar districts in Afghanistan with the highest maternal mortality. What I did in the beginning, I started stakeholder mapping to know who is doing what in terms of provision of health services. So I found out community leaders, shrine, traditional healers, shops, shrine, and I established district health coordination committee meetings to bring everyone together. We started monthly district health coordination committee meeting, and we were also trying to find out their role, their existing role, and also to see how much their existing roles can be further improved to play a positive role rather than negative role. Because if you remember the Miriam story, Miriam's approached most of those centers, but their health was not improved. We started learning also from the community. We started monthly coordination meetings. We were discussing about the challenges in the communities, recommendations from the communities. We also discussed the existing health services, the public health services, their roles. We also started brainstorming from the community to give us recommendations, what could be improved. And we also list of those challenges, and also we discuss why many people are dying. In fact, the health system is even not properly utilized. So the two districts that I'm mentioning was also with the poorest health utilization indicators. It means the clinics, the ambulances, the community-based health centers that we had that was underutilized. So now, at least people are connected. We also connect the dots. Connecting dots means we connected, the shrine, we connected traditional birth attendants, the shops, traditional healers, religious scholars, whoever was providing services to the public health system. And we also identify some of the side effect, or let's say, the adverse, or maybe the challenge that they were also creating, to the health of those people that they were using the services. So connecting dots help us to connect everyone also with the health system. Even the health system was also, we explained to them that, well, that also need to be community-based centers. So community-based approach. So everything was just connected. Well, only the connection was not enough. We also moved further to the next step. We started developing information communication materials. We firstly reviewed the existing information education materials about the health messages, about health-seeking behaviors, about information about the health system, how much people are aware of from the existing services, why they are using, referring, mostly to these traditional healers, or maybe to the shrines, or buying medicines also from the shopkeepers without knowing the name of the medicine. And then we also assess, the current communications between the health facility staff and also the patient. Unfortunately, because of the local terminology, most of the healthcare staff, that they came from the capital of the province or capital of the country, they were not properly understanding, each other's language. So we found barriers in communication between healthcare providers and patient. That was one of the reasons why people were not really using, the services. We also identify that the existing materials was national-based developed. In developing countries, so the level of inequality is very high. So you will find, maybe 80% of the literacy in the capital of the country, 10% in the capital of those districts, or maybe the area that I was working. So when the level of inequality is that much high, so those materials that they were developed for the capital of the country were also sent to the capital or maybe to the remotest area. So that's why they were not properly understanding. We were also told by the community, as long as this was the community approach, we were told if we record the sound of those health messages by the religious scholar, by the community leaders, so that will also give us further strength that community will easily listen to their messages. It will be with their own accent, with their own terminologies, with their own reasoning, with their own pictures. Because the picture that we used was from the capital of the country with the tie. So these people were not very happy to see somebody with a tie, somebody with a suit. So that contextualizations, putting together things always help us to bring community closer to that. So now I remember, let's get back to the story of Miriam. So Miriam, now she is part of the project. So she has been advised properly by the community to get to the health facilities, to get to the clinics on the right time. So now, in order to give more ownership to the community, we also started community monitorings. Through community monitoring, what we did an important job with the community. So we started, community mapping. Through community mapping, we identify the area that they are still not being able to properly come to the clinic and use the services. And with the community mapping, so that list was also given to the clinic staff at the clinics and hospital on monthly basis. We were also reviewing, that list. How many people have been visited, have been checked also in the clinics from that particular area? Because in community mapping, we highlighted the important people that they need to, specifically pregnant women, to come. We were also advised two other important recommendations: to start community outreach services for those pregnant women that they could not visit the clinics. So we were having their list, despite the fact that we were trying also to encourage them a lot, but they could not visit it. We started community ambulance services and community outreach services. The other important aspect that we were also told by the community is maternity waiting room. So community paid to build 2 rooms attached to the health facility with the community contribution, and we were able also, specifically those pregnant women that they were coming to the clinic and we didn't have space for them to keep them in the clinic and send them back, to their own area and come back. So that was something very helpful. And now Miriam let's get back to the Miriam. So Miriam referred to the same clinic. She has been also using the maternity waiting room. She spent 2 nights successfully, and then after 2 nights, she delivered in the clinic successfully. She got a newborn baby, and Miriam is now healthy. And that Miriam's successful story, also the news went back to the village, and also there was a still positive changes in the community. So now let me tell you, the community engagement, community involvement is not only important in the developing country, it's also very important in developed part of the world, in UK, in US. We remember the story of Kuwait. So during the COVID-19, what happened, if you remember, community were not involved during the first wave and second wave of Kuwait. So that's why the mortality, because of the Kuwait, was very high, specifically in minority, because they could not properly understand also the messages that was developed by NHS here, and also the same in US. In US, if you remember, the mortality was very high among African American. So here it is the same. So now to tell you, the last important things, now we brought a positive changes there, but important message is now to us, if I put a question to all of us, so what part of the community you are? Have you been also involved that the community you are part of it? What change that will make if you involve further communities in the work that you do? Thank you very much. Final words after the question is still important. Let me tell you something about the Miriam. So the project that we completed, we reduced also the cost by the community intervention. So now the national health policy of the country is revised based on the lesson learned from the Miriam story. And the 2 districts with the highest maternal mortality is not anymore the highest district, and these are the safe districts, and mortality has been reduced significantly in these 2 districts. And 2 districts has been also recognized as a successful districts in terms of provision of health services. Thank you.